Hello, and thank you for tuning in to Health Professional Radio. I'm your host, Neal Howard. Thank you so much for joining us today. Dr. Pepper Schwartz, she's professor of sociology at the University of Washington and a leading relationship expert on Lifetime's Married at First Sight. And she joins us here today on Health Professional Radio to discuss female sexual dysfunction and its most common form, known as hypoactive sexual desire disorder, or HSSD. Welcome to the program, Dr. Schwartz.
Thank you. Thank you for having me. I appreciate it.
Now, you're a PhD professor of sociology. How did you come to be an expert in sexual issues?
I study both men's and women's sexual health, and often in the context of relationships. And the way I came to that was when I was going through graduate school, and it was the beginning of the women's movement, the civil rights movement, the gay movement. There was a lot of sense of people claiming their right to be whoever they were and to get better knowledge about it, to stop the stigmatization and stereotyping of who other people thought they were. And I realized that there was very little good research, first concerning female sexuality, because I was a woman and I could recognize a lot of myths that didn't apply to me, or I sure wanted to know if they were myths or not. But also I feel that sexuality has been stigmatized, and the part of the women's movement at that time was, in fact, to reclaim our right to be sexual and our right to have knowledge about it. And so that's how I started doing research, because there wasn't much around. I was impassioned about these topics that I'm just telling you about now, and we were all kind of pioneers at that time. This was in the late 60s, early 70s. So I educated myself to what I could, and then I did a lot of research projects to be able to separate some fact from myth. And then I saw it as an educational mission, because not only then, but now we have a lot of women who don't feel empowered about their sexuality, don't talk about it, don't do anything but, as we found out in one study by ASHA, they just deal with it as opposed to have an answer and have the permission to go to health professionals or get a reception from health professionals that would help them sort out their sex lives and make it more fulfilling and satisfying.
So we're talking the late 60s, early 70s, and as you say, wanting to be recognized for who and what you are. The term female sexual dysfunction, when you were doing your research in those early days, did your findings have different terms, things that maybe we would understand as something else back then? I mean, we hear about male sexual dysfunction and we have this picture that's been kind of droned into us forever. But when it comes to the female side of sexual issues, whether a problem or not, what about the terminology? Some of it's obviously archaic.
Right.
What about that? How can we latch on to what is actually going on?
Well, the term female sexual dysfunction is relatively new. And of course, we'd rather be talking about female sexual function. But the fact is, it's recognition that there's been a lot of problems that hadn't been talked about and haven't actually had focus on as either medical or, for that matter, other kinds of explanations for women's sexual lives. Basically, the four things that are labeled under female sexual dysfunction, arousal, desire problems, arousal problems, orgasm problems, and pain problems, have been, quite honestly, swept under the rug or not considered important by the public and by the professions until, I think, recently in an organized, medical and psychological way. They have been talked about. When I was in the late 60s and 70s, we had consciousness-raising groups. We talked about this, but there were huge stigma about talking about it. That was a great breakthrough then, but it remained almost a woman to woman and not in terms of clinical responses. Masters and Johnson began to talk about the physiology of sexual response and gave us permission to talk about the physiology of sexuality and to try and learn our bodies. And that was a very important breakthrough. But, some of it has really stayed, in that sort of private therapeutic area without really thinking about focusing on on some of the arousal and desire parts of it. In fact, what is interesting in terms of this study that a Harris poll that the American Social Health Association did was that of all the problems under female sexual dysfunction, the most common one that women self-identified and complained about was sexual desire, its absence and the problems with arousal and some of them, which got classified under HSDD, hyposexual desire disorder, when we realized that some of these women weren't talking about temporary things. They were talking about persistent problems with desire and arousal that was lasting over 6 months and was affecting their lives and their relationships. We didn't have language for that. We didn't think about it in terms of, other than it had to be caused by some relationship issue, or maybe we concentrated on the pain problems or the orgasm problems. Those were in some ways much easier to locate and to deal with. And so they've gotten a lot of the press and they've gotten a lot more help. But desire and arousal started to get classified, only under maybe relationship issues. And God knows sometimes that is the explanation. But it's not always the explanation. And so we've developed new medical and clinical knowledge to take a closer look at all the complex reasons someone might have lost, what we call their spark, what turns people on, what makes them responsive to each other, to how they can create a satisfactory erotic feeling and desire for their partner.
So we're talking both mental, environmental, and physical aspects of HSDD as it relates to the arousal part.
Right. We are. Sexuality is a very complex mechanism, our mind's involved, our bodies can be involved, things that are situational and environmental can be involved, or they could be long-term physiological issues that require medical conversation and diagnosis with a health provider. What we want to do is take it out of the shadows as something that women are just dealing with, which is what the ASHA program showed, that while 49%, not ASHA program, the ASHA survey showed that while 49% of women said they had some kinds of problems with arousal and desire and all these other things with pain and orgasm, et cetera, only 4% of those women had ever talked to anyone about it and just try to, live with it, think that's kind of what you had to do. So what I want to do is get the conversation going with health providers to say, hey, this is a common issue. We want you to investigate it. We want you to feel the freedom to talk to women about their sex life, and we want women to know that you'll either have a response for them or you'll have a recommendation and referral for them.
So have you seen a surge in this welcoming response to women who have physical issues as well as being referred to doctors such as yourself for mental or maybe relationship issues when it comes to sexual desire disorder?
I think we've been better about talking about sexuality in the context of relationships than we have in empowering women on understanding their own sexual response as a woman all by themselves. For example, if a woman masturbates and she feels no sexual arousal, it does nothing for her. She feels she has no sexual fantasies. She just doesn't know where it went. Women who used to have this feeling, who have lost it, I don't think there has been a very adequate response to those women to help them get back what I consider a lifelong gift of sexual response and to understand what is going on outside of the context of a relationship. Because sometimes, if a therapist does a sort of a proper checklist, and at the findmyspark.com internet site, we give a checklist of things that people might think about that would explain how they feel and to see, whether it is coming from, possibly medications or a relationship problem or they're perimenopausal or there's some reason that's easily at least explainable, complications from health issues. We want a total review, of all the things that could be causing this. But if those things aren't present, I think a lot of health providers just hold up their tent and say, gee, must be mental, because they don't even look for the physiological. Maybe sometimes if they're endocrinologists, they work in, those things. They should, it should be a part of a wellness checkup, in my opinion, because we don't want to think of sexuality as some black box that, if we don't think we're specialists, we just don't get near it. I mean, we at least owe our patients, our clients, our friends, our lovers, the care of taking a sexual response seriously and not just saying, well, it just goes away and we don't know why, but so be it. I mean, we should know why, and we should think of all the ways we might be able to address that issue.
Well, I thank you for talking with us about this subject. I'm hoping that you'll come back and share some more knowledge with us in other segments.
I'd love that. Thank you.
You've been listening to Health Professional Radio. I'm your host, Neal Howard, with Dr. Pepper Schwartz, professor of sociology at the University of Washington, talking about female sexual dysfunction and its most common form known as hypoactive sexual desire disorder. Transcripts and audio of this program are available at healthprofessionalradio.com.au and also at hpr.fm. You can subscribe to this podcast on iTunes, listen in, and download at SoundCloud.